Welcome to The Explainer. Today, we're diving deep into a topic that's an absolute classic in the FRCS Orthopedics Viva: fat embolism syndrome. Now, we're not just going to read facts off a slide. We're going to build that mental framework you need to absolutely smash your answer when you're in that hot seat.
Okay, let's just jump straight in. Picture this, you're in the Viva, they give you a polytrauma patient, femur fracture, and suddenly they become hypoxic and confused. The clock's ticking, the examiner's looking right at you. What's the first thing that springs to mind? It has to be fat embolism syndrome.
So here's our game plan for today. First, we'll define what we're up against. Then we'll figure out who's most at risk. We'll cover the clinical picture, how to diagnose and investigate it, and of course, how to manage it. And we'll wrap up with some high-yield tips on how to nail this in the Viva. So let's get into it.
Right. First things first, we've got to start with the basics. Getting a crystal clear, concise definition and a real grasp of the pathophysiology, well, it's non-negotiable. This is where you lay the groundwork for a truly excellent answer.
Okay, this is probably the most crucial distinction you can make right at the start. Fat embolism, just fat floating around in the blood, is incredibly common. It happens in something like 90% of long bone fractures. But fat embolism syndrome, the actual clinical disease we're worried about, is much, much rarer. Making that distinction immediately shows the examiner that you get it, you understand the fundamentals.
Now for the why. What's actually going on in the body? Well, there are two main theories, and you need to know both. The mechanical theory is pretty easy to picture. Fat globules literally get squeezed out of the bone marrow and clog up blood vessels. But the biochemical theory, that's what explains the delayed onset and that ARDS-like picture. See, it's the breakdown of that fat into toxic-free fatty acids that causes this massive inflammatory storm. A top-tier answer has to include both.
Okay, so we know what FES is. The next logical question has to be, who gets it? Identifying that high-risk patient is a huge part of your clinical game, both in the exam and on the ward.
Let's put some numbers on this to ground ourselves. The overall incidence is pretty low, right? About 8 per 100,000 trauma patients. But, and this is a big but, in polytrauma, that number can skyrocket to as high as 15%. So what does that tell you? The sheer burden of the injury is a massive, massive risk factor.
And this table right here, this is your high-yield summary. The absolute classic patient is that young guy, 10 to 40 years old, with multiple long bone fractures, especially bilateral femurs. But don't get caught out. Examiners love to push the boundaries of your knowledge. Being able to mention non-traumatic causes, like pancreatitis or even liposuction, shows you've got a really comprehensive understanding.
Now this chart is fascinating because it illustrates a really key point. While the younger patients get it more often, they have the highest incidence, it's the older patients who have a much higher mortality. And why is that? Well, they just have fewer physiological reserves to handle that kind of systemic hit. That is a critical piece of information when you're thinking about prognosis.
All right, let's move to the bedside. What are you actually looking for? How do you spot the syndrome when it's unfolding right in front of you?
The key thing to remember here is the asymptomatic interval. You see, the patient is often okay for that first day, and then they start to go downhill. That delay, that's the biochemical theory in action. It just takes time for those free fatty acids to get produced and start causing damage. This timeline is a total classic. This slide is the absolute heart of the clinical diagnosis: respiratory, neurological, and skin signs. You have to know this triad inside and out. But here's the crucial nuance, the bit about the rash. It's often called pathognomonic, right? But its absence does not rule out FES. That is such a vital point to make in your answer.
Now, in the exam, you've got to be able to mention the historical scoring systems. The big names you need to remember are Gerd and Wilson, Lindake and Schoenfeld. Just knowing them shows you've done your reading. Gerd's criteria, the one with major and minor features, is probably the most famous of the bunch.
But here it is. This is the consultant-level insight that's going to make your answer really pop. After you've listed those scoring systems, you add this little critique. It shows you don't just memorize facts, you actually think about the evidence. You acknowledge their history, but you highlight that, their clinical use today is pretty limited. That's a game changer.
All right, so you've got a strong clinical suspicion. How do you back it up? Let's talk about the investigations you're going to order, and, just as important, what you're actually looking for.
This sentence right here, this is probably the single most important sentence in this entire section. You should say it out loud in your Viva. The diagnosis is clinical, and it's one of exclusion. There's no magic bullet, no single blood test or scan that's going to give you the answer. It's all about putting the pieces of the puzzle together.
So, your workup has to be logical. You're going to start with an arterial blood gas, right, to see just how hypoxic they are. A chest X-ray might show that classic, but remember, nonspecific, snowstorm pattern. Then you've got CT and MRI to give you more detail on the lungs and the brain. And hey, don't forget point-of-care ultrasound, POCUS. It's a quick tool you can use right at the bedside that might even show fat particles in the heart.
And here we are. This is it, the most important section for any Viva. The examiners don't just want to know if you can diagnose it, they need to know that you can manage it. This is where you prove you're a safe and effective surgeon.
If you take only one thing away from this whole explainer, please let it be this. The single most effective thing you can do for FES is to prevent it. And you do that with early, definitive stabilization of those long bone fractures, ideally within 24 hours. You're closing the tap, stopping the continued leak of fat emboli. This is, without a doubt, your #1 priority.
Once FES has actually developed, there's no magic cure. The treatment is all about supportive care. Your job is to support the patient's vital functions while their body fights back and recovers. This means being aggressive with respiratory support. We're talking mechanical ventilation and high PEEP to keep those lungs open, plus really careful hemodynamic and neuromonitoring.
Ah, the steroid question. This is another Viva classic, and your answer has to be nuanced. For prophylaxis, that is, preventing FES in high-risk patients, the evidence suggests there might be a benefit. But once FES is established, their role in treatment is pretty much unproven. Giving that kind of balanced, evidence-based answer shows you are on top of the literature.
Okay, let's bring it all home now. This final section is pure exam gold. We're going to run through the common traps that people fall into, the buzzwords that'll make you sound incredibly sharp, and what the long-term outlook is for these patients.
Let's be really direct here. Do not make these mistakes. We've talked about all of them. Don't mix up the common finding with the rare syndrome. Don't call GERD's criteria the gold standard. Always, always lead with early fixation. And please, know that finding fat in the urine or sputum is an old, unreliable test.
And here are your buzzwords. Try to weave these key phrases into your answer. Think of them as a kind of shorthand that just signals to the examiner that you have a really clear, structured way of thinking about the most important concepts we've covered today. And finally, to really leave you thinking at that consultant level. The acute crisis is over, the patient is better, but your job's not done. While most patients do recover fully, you have to be aware of potential long-term problems like pulmonary fibrosis or even persistent cognitive issues. Thinking about the patient's entire journey, well, that's what separates a good candidate from a qualified surgeon.